Good evening, everyone. I'm going to talk about another challenging topic regarding the update on devices and valvular heart disease. A very challenging topic which is commonly seen in the daily practice. Patients who have tricuspid valve disease, mainly tricuspid regurgitation. This is my disclosure. And we know that tricuspid regurgitation is unsolved clinical challenge in patients at prohibitive or at high surgical risk and is associated with poor prognosis. Secondary, tricuspid regurgitation, tricuspid valve annular dilatation, and right ventricular dysfunction will cause right side heart failure. And this slide shows that the majority of tricuspid regurgitation is due to left side heart pathology, like degenerative mitral regurgitation or functional mitral regurgitation, aortic stenosis, LV dysfunction, pulmonary hypertension, with the increase in left atrial and left ventricular pressure, pulmonary artery pressure, right ventricular afterload, right ventricular dilatation, remodeling, and dysfunction, which will lead to malcoaptation of the leaflets, tinting and tethering of the leaflets. This would increase the severity of tricuspid regurgitation with time, more volume overload, and decrease in the right ventricular forward stroke volume. At the end, this will end in right side heart failure. We'll have patients with edema, fatigue, liver injury, kidney injury, and dyspnea. So the significance of tricuspid regurgitation regarding the outcome, these two important studies, one study which was published in JACC 2004 that evaluated 5,500 patients, consecutive patients undergoing echocardiography for different grades of tricuspid regurgitation, and they demonstrated that increasing tricuspid regurg severity is associated with worse survival in men, regardless the ejection fraction, regardless the pulmonary artery pressure. And they concluded that severe tricuspid regurgitation is associated with poor prognosis, independent of age, biventricular function, and right ventricular size or dilatation of the inferior vena cava. And on the right, in another study, that patients who have tricuspid regurgitation more than grade 2, the cumulative survival is much lower compared with the patients who have lower grades of tricuspid regurgitation. And recently, we have different transcatheter tricuspid approaches can be used in those patients. We have coaptation devices, suture angioplasty, ring angioplasty, and we have transcatheter tricuspid valve replacement and heterotopic cable valve implant. So the recent developments in valvular therapy have made percutaneous tricuspid valve repair is feasible in patients at high surgical risk. So which transcatheter technique can we use for tricuspid regurgitation? We have the cohabitation devices, and we have the angioplasty devices. So Cardioband, one of the devices which is commonly used, the Cardioband tricuspid repair system. And the idea is direct sutureless and adjustable surgical-like dacron band. The device is inserted through a transfemoral 24 sheaths and up to 17 anchors can be deployed on the atrial side of the anterior and posterior tricuspid annulus to fix the device with a successful outcome. So one of the important diagnostic tools and imaging modality which is needed before doing this procedure is to do CT, because computed tomographic imaging can allow evaluation of anatomical landmarks which are important. For example, for cohabitation devices, tricuspid annular dimensions, distance from tricuspid annulus to right ventricular apex. For angioplasty devices, the course of right coronary artery is very important relative to tricuspid annulus to avoid injury of the RCA during the procedure, distance from the RCA to anterior and posterior tricuspid insertion, and CT is considered in addition to transesophageal echo during the procedure are mandatory to avoid complications and to allow for proper guiding for a successful procedure. So this is one of the important studies, which is the CardioPand tri-repair study for the reduction of CardioPand in patients who have severe tricuspid regurgitation. And the outcome of this study was associated with the significant reduction in the severity of tricuspid regurgitation, as well as significant reduction in the septolateral annular diameter, which is an end diastolic septolateral dimension from the transthoracic apical four-chamber to evaluate the size of tricuspid annulus. A diastolic dimension more than 40 millimeter, indicating severe tricuspid annular dilatation. In addition, significant improvement in clinical outcome in terms of improvement of the NIA function class, decrease in the grades of edema, as well as improvement in the 6-minute walk distance, as well as improvement in quality of life, estimated by Kansas City Cardiomyopathy Questionnaire. Another study, which is TriLuminate, which included patients with heart failure function class 3 to 4, high Euro score, high levels of NT-proBNP, low estimated figure for TAPSE, indicating more RV dysfunction, and NT-proBNP level is high. Tricuspid severity, the majority have torrential and massive severe tricuspid regurgitation, and the outcome of this procedure in patients with severe tricuspid regurgitation was associated with significant reduction in the grade of tricuspid regurgitation. 87% showed at least 1 grade improvement at 1 year, and 70% after 1 year have a moderate or less degree of tricuspid regurgitation. In addition to reverse RV remodeling detected by significant reduction in right ventricular end diastolic dimension, as well as decrease in right atrial volume and increase in TAPSE. So the safety issue for any novel modality of treatment is important, and this was confirmed in TriLuminate study in terms of very low incidence for complications in the form of cardiovascular mortality, myocardial infarction, stroke, all-cause mortality, major bleeding, as well as thromboembolic complications. So this is an interesting study which was published in JACC last year for transcatheter edge-to-edge tricuspid repair for severe TR, which proved to reduce hospitalization for heart failure. Isolated the transcatheter tricuspid valve repair and combined tricuspid and mitral valve repair also reduced heart failure hospitalization, in addition to improvement symptoms up to 1 year, estimated by NIA function class, 6-minute walk distance, and heart failure related quality of life, stabilize the diuretic doses, and it lead to reverse RV remodeling. And this slide summarizes the outcome of this study in terms of reduction in heart failure hospitalization, as well as decrease in the mortality. Again, for patients with subjected to transcatheter tricuspid valve repair only, or tricuspid and mitral repair, the reduction in heart failure hospitalization was significant. And this is example for pre and post transcatheter tricuspid edge-to-edge repair. We can appreciate on the left severe degree of tricuspid regurgitation and successful procedure even up to 1 year, no residual tricuspid regurgitation. Another example, pre and post, different degree for severe tricuspid regurgitation, which ameliorated and successful procedure for transcatheter approach to decrease the severity of TR, and the outcome was better in patients with no pulmonary hypertension, and the survival was not good for patients who have pre-capillary pulmonary hypertension compared with patients who have post-capillary pulmonary hypertension. So the cardiopulmonary hemodynamic profile, according to this paper, predicts the mortality after transcatheter tricuspid valve repair in chronic heart failure. This is an example for heterotopic tricuspid valve and orthotopic evoco valve with severe tricuspid regurgitation and up to 15-month follow-up, the residual minimal degree of tricuspid regurgitation. So what about the guidelines, the EC heart failure guidelines that address this question regarding the presence of tricuspid regurgitation in heart failure, that the heart team approach should be considered for assessment and treatment planning, and transcatheter technique have recently emerged as potential treatment option for TR. Preliminary studies show improvement in TR severity and symptoms with low complication rates. Again, we can appreciate in the EC guidelines for management of tricuspid regurgitation that transcatheter treatment of symptomatic secondary and severe tricuspid regurgitation may be considered in inoperable patients at a heart valve center with expertise in the treatment of tricuspid valve disease. This is class 2B recommendation level of evidence C. And this interesting algorithm for patients with severe tricuspid regurgitation in need for left side valve surgery. So those patients should be subjected to tricuspid valve repair or replacement, which is the gold standard surgical approach, while patients who are not candidates for left side valve surgery, who have severe symptomatic tricuspid regurgitation, evaluation for transcatheter therapy should be considered. And in absence of severe RV dysfunction or severe pulmonary hypertension, tricuspid valve repair or replacement is an option, which is the class 2B recommendation. And this is another very interesting algorithm in a paper which was published in JACC 3 years ago, that in patients with primary tricuspid regurgitation at high surgical risk, for patients who have collapse, mitral clip is an option. Transcatheter tricuspid valve replacement in patients with rheumatic etiology and the lead-induced tricuspid regurgitation with extreme annulus dilatation, coaptation devices, and valve replacement can be considered. And according to the stage of tricuspid regurgitation for patients who have secondary tricuspid regurgitation, because in the early stages with the initial dilatation of the right ventricle without significant leaflet tethering and in the presence of normal RV function, annular-based system devices, annuloplasty is an option to avoid the recurrence. And in patients with second stage progressive RV dilatation, tricuspid annular dilatation, and in the presence of normal RV function, a combination of cohabitation devices or combination of different approaches, edge-to-edge repair can be done. And transcatheter tricuspid valve repair also is an option. With advanced stages of RV dysfunction, those patients with end-stage heart failure, medical treatment is an option. However, in more advanced stages, also transcatheter tricuspid valve repair or caval valve implantation can be considered. Thank you for your attention.
Thank you very much, Dr. Magdy. And please, Rosano, your thoughts on this, please.
Magdy, great talk as always. One question. Do you think that we should, rather than going on severe, just on the severity of mitral regurgitation, we should go for the combination of the degree of regurgitation and the type of hypertension, pulmonary hypertension, and the degree of pulmonary hypertension? Do you think we should, in the future, should combine the two things, or we just go and give an indication when the tricuspid regurgitation is very severe?
Still a problem with internet.
Yeah, thank you very much, Professor. I think the presence of, because I have a problem in the connect. Yeah. I think the presence of pulmonary hypertension usually is associated with RV dysfunction. And the presence of RV dysfunction, especially advanced stages of RV dysfunction in the form of low ataxia as well as RV longitudinal strain more than -23, which are indicating poor RV function. So in this situation, the outcome for transcatheter repair is not good compared with the patients with the normal RV function. So I shown a slide which compared the outcome in patients with pulmonary hypertension compared with patients without pulmonary hypertension, and the survival was good in patients who have no evidence of pulmonary hypertension. So I think that the presence of severe pulmonary hypertension identify patients who are not good candidates for transcatheter mitral approach.